Hello, everyone. Welcome to the International Mentorship Program. This is Kate Barlow, and with us today is David Thomforde, and he is doing part 2 of spinal cord injuries. Thank you, David.
So good morning, Regina and Afisa. I'm glad to see you're both here. We worked together last time and 3 years ago, and I hope we work together again. This, as you know, is the second part of this presentation, because spinal cord injury is a very large topic for occupational therapy. I would like to spend about 5 minutes going over the different topics that we covered in the first presentation. So to begin with, we talked about level of injury. As you know, spinal cord injury depends on where on the spinal cord the injury has happened. And we're talking mainly about traumatic injury here. People who have injury in the cervical area, especially the high cervical area, are likely to be quadriplegic, meaning they don't have use of their hands or their arms or their legs. And they're often dependent for most activities unless they have some sort of electronic equipment. And they also, they may even be dependent on a respirator for lung function. Somebody who has injury in what's called the low cervical area of the spine would also be called a quadriplegic, and they're likely to have use of their shoulders and, depending on where the injury is, limited use of their hands. Somebody who has injury in the thoracic area would be a paraplegic. They would usually have use of their arms, but they wouldn't have trunk muscles, so they'd have trouble sitting balance. No use of their legs, so probably using a wheelchair. And then somebody who has injury in the lumbar or sacral area would be a paraplegic. They're likely to have fully functional arms, fully functional trunk muscles, but limited use of their legs. So they might use a wheelchair. They might walk with braces of some sort. They most probably have problems with bowel and bladder control, though. We also talked about stages of injury. An acute injury where somebody's just had the injury, there's often swelling in the spinal cord, which will further decrease function in the spinal cord until the swelling goes down. And usually we do not do much treatment in occupational therapy during that period. We wait until the swelling has gone down, and then we see what level of function the person has. We also talked a little bit about types of incomplete injury, because depending on what injury happens, there can be a mixed bag of where the person can have movement or sensation. We talked about medical issues. We talked about autonomic dysreflexia. This is a medical emergency, which is most apt to happen with somebody with a high spinal cord injury. And it means that the body is somehow responding to a stimulus and is sending the blood pressure sky high, and can result in a stroke or a burst blood vessel. It can be caused by such trivial things as tight clothing or a bowel impaction or a overfilled bladder. The OT role is one thing to get medical treatment, and the other thing is to raise the person's head, thereby decreasing blood pressure in the head and also trying to identify what the cause of the problem is. There's also orthostatic hypotension, which is almost the opposite, where the body is having trouble pumping blood up to the brain. It's not so serious. The person's likely to faint, but other than that, all you have to do is lower the head, raise the feet, so the body has more possibility of pumping blood to the brain. Before we go on, any questions? I will be stopping on a regular basis to ask for questions. Any questions from now at this point?
You will have to unmute yourself if you want to ask a question, because I try to keep everybody muted while David is talking. So make sure you unmute yourself first.
Okay, if not, another medical issue is pressure sores. As we talked in Guyana, you know that if a person lacks sensation and there's compression between the bone and a surface, they can develop a sore there. The most likely place is the ischial tuberosities when a person is sitting. And we talked last time about how they're caused and how a person sitting can relieve the pressure on their ischial tuberosities, either by leaning forward, leaning to either side, or having the whole wheelchair tipped back. We also talked about spasticity, which is sudden reflex movements of the arms and the legs, most common in people with higher level injuries, and the fact that they can be very painful, they can decrease skilled movement. If you suddenly have a jerk of your arm, it's difficult to eat, but they also can be useful. Some people learn to control spasticity, for instance, to have a spastic extension of the knees, helping them to stand. And then finally, we started to talk about the role of occupational therapists in ADLs, in eating and in shaving. And we also talked about how you evaluate a patient as an occupational therapist. One is using a manual muscle test, which we spent a lot of time on, Regina and Afiza, deciding what muscles the person can move and what the level of strength of them is, whether they can move against gravity, whether they can move against resistance, whether they can simply move in gravity-limited positions. Also a sensory evaluation to determine where the person has sensory input, where they lack sensory feeling, and also whether they have their ability to transfer what it is, and their ability to do ADLs, and their ability to move around, whether they need to use a wheelchair, whether they can walk, and finally, passive range of motion limitations. So that in a very large, very small nutshell is the things we talked about last time, basically an introduction to spinal cord injury and the OT role. Any questions there? You all have it on the PowerPoint that we have. So this is a review of the basic issues that we talked about during that first session. And then we just started talking about these: eating, using a universal cuff if you have no grasp, having a bowl with steep sides so you don't spill so much, having large handled utensils if your grasp is functional but weak. So if you're working with somebody, again, please stop me or write a message if you have a question, but if not, we'll keep on going. As you know, Regina and Afiza, I tend to talk fast, so please, if I'm going too fast, ask me to slow down. So a person who you're working as an OT on them for dressing, the big problem they would have is they would have problems grasping things, holding onto their pants, holding onto their socks. So what we can do as OTs is we can sew loops on the clothing. So rather than having to grasp the pants, the person can hook a finger through their pants and pull them up. Another thing we often work on is positioning while dressing. If you're sitting and having to pull your pants up under your bottom, you have to stand up, which can be really difficult if you have weakness in the legs or if you have basically weakness in the legs and trunk. But if you have the patient lie on their back, they can use their arms to bend one leg at a time, cross it over one knee at a time, and then they can get the pants down over their feet. And then once the pants are over their feet, then they can roll from side to side and pull the pants up on one side at a time. There's also a device called a button hook. There's a picture on it here. It can be fabricated. Calvin, one of Regina and Afiza's fellow students, made one out of a safety pin when I was teaching in Guyana. But you can buy them off the internet. And basically, you use the left end to hook over a button and then pull it through the buttonhole. And it has a little useful little hook on the other end that you can use, for instance, to hook onto a zipper pull, because zippers pulls are really small and hard to grasp. But if you can hook that on, then you can pull the zipper up. So those are some ideas of somebody to help somebody with a spinal cord injury work on dressing. Shaving, this device on the right is an electric shaver, but it could also be a safety razor that's attached to the person's hand with a strap. So the person can use normal movements to shave even though they're unable to grasp the safety razor or the electric razor. I'm pausing here just if you have questions. If you're typing and you have trouble typing fast, then you can just start to type and that will alert Kate that you have a question. Bowel and bladder management. This is a role where OTs and nursing work together. Nursing is important because if a person doesn't have good bowel and bladder management, they can develop bed sores from having constantly wet skin. They can develop a bowel impaction. They can develop many medical complications that cause problems. So that's why nursing is involved. What we do is we help the person carry out a program with less assistance from a helper. It is a complicated field in itself. It requires extensive study. So we'll just review it briefly here. But people with spinal cord injury usually require catheterization, which is a process whereby a tube is inserted into the urethra through the penis or through the female genitalia, and it's inserted into the bladder and urine is drained out of the bladder. It can be a indwelling catheter that stays there and drains constantly into a bag, or it can be an intermittent process whereby the tube is put in and taken out. That has a major advantage of decreasing the possibility of a bladder infection. So most people with spinal cord injury, if they can, have this intermittent catheterization process. There's also a bowel program that consists of training the bowel to evacuate at a specific time every day. You imagine the difficulties of a person who's trying to manage and not knowing any time when they're going to have a bowel movement. So you train the bowel to evacuate at a certain time every day, and you use that by inserting suppositories that ease evacuation, by doing a process called digital stimulation, which is inserting a finger covered by a protective cover into the anus or a device and moving it around. And all these things stimulate the bowel to evacuate. So basically our OT role is either prescribing or designing adaptations. A person who cannot insert a finger, who doesn't have control over the fingers sufficiently to insert just one finger in the anus, can use a device that has a finger-like knob on the end and a handle, and therefore they can insert in the anus. Often they would need a mirror too. So you would prescribe the person a mirror so they can see what's happening, because they probably would not have feeling in their anus. If you need more information about bowel and bladder programs, there's a website here you can get more information. So that's just an overview of bowel and bladder. It is more complicated than that. You need more information. If you're working with a person on bathing, the main recommendation is to have a chair in the shower so they can sit. Obviously, standing is difficult for a person with most types of spinal cord injury. So a chair to sit on is useful. And then some way of holding the soap. And that I've put here a small picture of a mitt that you can put over your hand. It can be a washcloth that's sewed up on the inside and then turned inside out. There are other possibilities. One is a squeeze bottle of soap, liquid soap. And the third possibility is making a hole in a piece of soap and putting a rope through. That allows the person with limited hand function to hold on to it. But after that, the person would bathe as much as they can reaching the areas with arm function as much as they can, and then the other areas somebody would have to help them with. Any questions here? Going at good speed? Anyway, oral care. If a person wants to brush their teeth, an electric toothbrush, if they have access to it, is the best thing. And that can be attached to the hand with a universal cuff strapped to the hand, or it can be enlarged so the person can use the toothbrush. But if a person has good arm function, they can brush their teeth without an electric toothbrush. For tooth flossing, there are little devices that you can buy that you can hold on to the end to floss your teeth. You don't have to wrap it around your finger. And then if a person has trouble getting the toothpaste out of the toothpaste tube, if they cannot squeeze it, they can put it under one elbow and lean to the side, or put under their palm and lean to the side and squeeze the toothpaste out of the tube. For writing, there are lots of different ways. We're basically talking about somebody who has arm function. They can move their arm, but they can't hold a pen with their hand. So on the left-hand side is a device made out of thermoplastic that allows somebody by moving their hand to write. But you can also, some people will just intertwine the pen between their fingers. Some people will take a lot, if they have limited hand function, but they have some, they may take a rubber ball, put the pen through the rubber ball, and they can hold onto that even though they can't hold onto a pen. There are many different devices for writing if you have a spinal cord injury and trouble with your hands. Now we do have people with a high cervical injury who do not have any hand function. These people can learn to use a mouse stick. A mouse stick can be bought commercially, or it can be fabricated if you have a piece of wood with like a rubber eraser on the end, and then you can take a piece of high temperature plastics and heat it up and then cool it down mainly and put it in the person's mouth and have them bite down on it. So that creates a mouthpiece that you then glue onto the piece of wood. And that person can use the mouse stick. They can use it for writing. You've probably seen people who have painting with a mouse stick, even turning pages. If the picture here on the right-hand side is of a person turning pages using a mouse stick, they need a stand to hold their book on. We can also talk about home care activities, and basically what we're doing is teaching a person to perform tasks from a wheelchair or how to perform them with limited hand function. So one thing that we often do is we recommend lowering tables to wheelchair heights so the person can cook or prepare food on a appropriate level from the wheelchair, and also reorganizing a kitchen or a bedroom for that matter so the items are accessible. So the person doesn't have to reach high for an item or reach low. All the items that are used on a regular basis are there. Also, depending on the person's hand function, we may recommend reachers or a cane or a stick with a nail in it to pick the items off the floor or get items off a top shelf. I didn't mention it here, but for some home care activities, if you have trouble opening a bottle, there are different devices that you can buy on the internet, or you can use like a wet towel to put around the bottle that will give you a little bit more traction on it. There are special openers for pill bottles if you have trouble with pill bottles. But most household activities, if you have the appropriate hand function, you can carry out most of these household care activities. And the OT's role is to work with the person on being able to learn to do them and to be more independent in carrying them out. Okay, we're doing well. We're going at great guns. Any questions here? Any things to bring up? Any, not only questions, any experiences that you've had with a patient that you'd like to bring up, like to mention? maybe something I haven't mentioned
You
here in one of the
unmute.
areas.
Sorry to interrupt you. You'll just have to unmute yourself if you'd like to talk, for those of you who just joined in, because I mute everyone to decrease the background noise while David is talking. So feel free to interrupt him at any time or type in the chat box because I'm constantly monitoring it. Sorry, David.
So again, if you do have your own experience in working with a person with spinal cord injury, maybe something I haven't brought up, I'd be most happy to hear it. Because remember, this is an opportunity for not just communication between myself as a mentor and yourself as mentees, but also communication with each other. To me, that's one of the important parts of this program, to build relationships between you and share experiences. Because to be honest, your experience may be much more relevant to another person from another country than mine, because you're living in more similar situations. There's my soapbox. Okay, I'll take a deep breath. We'll move on. Sensory loss. We tend to forget that a person who has a spinal cord injury, they lack muscle control, but they also lack sensory feedback from areas where the muscles are weakened. It's not always that where the muscles are weak, you also have sensory loss. There may be a strange damage in the spinal cord that will damage only the parts that cause muscle loss, but not the parts that cause sensory loss. So that's why during our evaluation, I mentioned it's really important to evaluate exactly where the person has the sensory loss and where they have the motor loss. But if you've determined that a person has sensory loss, especially in their hands, you need to teach them to visually monitor their hands and their arms, especially when they're close to sharp objects or hot objects, so that they can prevent injuring themselves. And then if you do have something that's hot, if you can train the person to test the object with a part of the body that has sensation. So for instance, if they lack sensation in their hands, if they're not sure whether a pot is too hot, or water in a shower is too hot, they may test it with their elbow, because their elbow may still have sensation. And that way they'll know if the water is hot enough to hurt themselves, too hot if they use their hands. And then the last topic to talk about is sex. This is, again, a complicated issue. Occupational therapists specialize in this area. We can't go into details here. There's a little bit more information below in this website. But the important thing to remember is that people with spinal cord injury are human beings, that men with spinal cord injury can sire babies. It may require some adaptive equipment. It may require a device to help the person maintain an erection, but it's possible. And the woman with spinal cord injury can conceive and deliver a baby. Again, it may require some medical treatment during the delivery process, maybe even a C-section, but it can happen. And this is because people with spinal cord injury have the same sexual urges, the same desire to be loved as any of the rest of us. And we as occupational therapists need to respect this. As an OT, one thing you have to do is you have to feel comfortable with it. And this is going to be difficult for a lot of people, but if you do feel comfortable with it, you can advise the people on such areas as positioning. The standard positions for sexual activity may not be possible for a person with a spinal cord injury. So you need to think about how the person and their partner can find comfortable positions that allow them to enjoy intimacy. I admit this is an area that I don't have experience in, but I would hope that some of you would be interested in this and would further explore it to be able to help people that you work with. And again, not just people with spinal cord injuries, but all your patients will have needs and desires in this area. So these are the different specialized areas within OT. Now we can talk about transfers. And just like bowel and bladder was mainly a responsibility shared between the OT and the PT, OT and the nursing, mobility is largely shared between the OT and the physical therapist. And there are many different kinds of transfers that you can use. A person with spinal cord injury can use a transfer board, such as this gentleman is using. You need to have a certain amount of arm strength. You need to have some trunk stability or the ability to balance with counterweight with your arms to use a board like this. But it is a useful way for a person who cannot bear any weight on their legs, or for instance, who might have spasticity in their legs that kicks in if they try to extend their legs. This could be a safe way of transferring. And a board like this can be purchased off the internet. It can also be fabricated with a piece of wood. You need to make sure it's nice and smooth, but it can be made locally. This would be called a pivot transfer here in the center for somebody who has difficulty, who has enough arm strength to push themselves up into a semi-standing position and to move over onto the bed. They need to have a certain amount of strength, but they don't have to have enough strength to stand. On the right-hand side is a forward transfer position. This person doesn't need to have that much strength in their arms. They just have to have enough strength to lift up their buttocks a little bit and move them forward onto the bed. We will have patients who have much more weakness in their arms, and none of these will be possible. And a person like that might need to be lifted, often with two people, or they might need some sort of mechanical lift, depending on what's available in the area. And just to mention that we as OTs also work on sitting balance, because any of these types of transfers will require sitting balance. If the person, and we use different games, ball games, doing ADLs while sitting, other games. And if a person does lack strength in the trunk muscles, they can learn to balance by counterbalancing with their arms. And you can try this yourself. As you lift up your arms, you can lean back further and still maintain your balance. So for instance, as the person leans back, they can raise their arms and that will counterbalance the weight of the body, the arms in front and the body back. And using that will be a way of developing sitting balance even if you have weakness in the trunk. Again, I would urge any of you who have worked with people with spinal cord injury to, bring up questions, bring up ideas, discuss people you've treated. We'll have some time for that at the end, but if something comes up in the middle, please mention it. Home modification. We talked about this a little bit when we talked about home activities. We talked about making beds and chairs at wheelchair height. But also it's very useful to replace stairs with a ramp. There are some very high-tech wheelchairs that can climb stairs, but they're very expensive. Usually a ramp is a better option. Ideally, a ramp should have a 1 in 12 slope. What that means is for every 1 inch of rise, there's a foot of length. It would also mean for every 10 centimeters of rise, there's 12 meters of length. I think that's right. Anyway, 1 in 12 is the rise to the distance. As you probably imagine, that is a really long ramp. That would mean if you had a 3-foot set of stairs to enter the house, you need 36 feet of ramp. Or if you had a 1 meter rise, that would be a 12-meter ramp. I'll be honest with you, that's the ideal. That kind of slope will allow most people who have any sort of mobility possibility function with their arms to get up that ramp. Most people if they have some arm strength or if somebody's pushing them, can get up a steeper ramp. So this is a standard, but it's really hard to achieve. So the basic idea is to have as gradual a slope as possible. But remember, I don't know, but many of you, I think you've been in places where businesses have put in ramps and they are about a 1-to-1 rise to steepness, and they put them in just because somebody said, put in a ramp, and it's really impossible for the person to go up in a chair. So you need to make the ramp as gradual as possible. You can even use a piece of wood and test the person out to see what sort of steepness they can go up. Here's a website that has some more information about making some of these, about measuring for some of these ramps. Also, if possible, you want to recommend making doors wider, 32 inches, if the person is using a wheelchair. Because if not, they're in great danger of banging their hands on the door frame as they go through, injuring themselves, injuring the door frame, much more difficult to get in. There's a lot more information about home modification. You can talk about size of bathrooms. You can talk about many different things, turning spaces, height of sinks, height of light switches, stuff like that. This ADA guidelines website has information on that too. For wheelchair prescription or modification, I do remember that those of you who are attending have already been to at least one talk about this later last year. It's also an area like many of these where you need to have more study, but basically you're determining the proper width of the body and length of the body to determine the width of the seat and the length of the seat, and also determine the proper height of the wheelchair, depending on the person's body measurements. And you're also determining, if possible, what kind of wheelchair the person needs. They may need a power wheelchair that has some sort of electric motor. They may need a light wheelchair if they're weak. They may need a sports wheelchair. Now, of course, needing and having are different things. So in an ideal world, you can go to the catalog and say, this is the wheelchair I want, and have it sent to you. But for most of us, even in the developed world, you're making do with what you have. So OTs can do a lot of adaptations of wheelchairs. If a person has trouble putting the brakes on, you can put pieces of pipe over the brake handles, giving you more possibility of leverage. If the person is having trouble maintaining an upright position, you can put padding on either side using towels. You can use straps to help to hold their body upright in the wheelchair. You can use straps to hold their feet onto the footrests. There are lots of different modifications we can make with local materials. But again, it does take more information than we can give in this session. Physical treatment. Again, this is the OT and the PT who are working on this together. One thing we do is we want to position the patient to prevent contractures. Now remember, at the beginning, the person with a spinal cord injury may have some edema in their spinal cord, so they may have greater weakness than they would develop later on. And while the swelling in their spinal cord is going down, they are in danger of developing contractures. So you may have a person who has no use of their hands during the acute phase, but after that swelling goes down, they start to develop using their hands. And if during that acute stage, their hands are flat, their thumbs are close to their hands, they'll develop what I heard one surgeon called fly swatters, which are basically hands that have no use other than hitting things. There's no possibility of grasping. This picture on the left is a person who's in a anti-deformity splint. And what you'll notice is that splint pretty much puts the thumb and the index finger close together. It also maintains the arches. It maintains this arch, the transverse arch, and you can't see it on the slide, but there's also another arch of the hand that goes through the MCP joints, and those are arches you need to maintain while the person is recovering. You also need to maintain the web space here. People who have full use of their hands have elastic skin there, so as they pull their thumb and their hand apart, it stretches, and they can pull their thumb a distance to grasp large things. If your hand is immobilized for a long time, then what happens is the skin in that web space loses its elasticity. And when you try and grasp something, you can't open your hand wide. So anyway, we would use different kinds of splints. If you have a splint, that's good. You can make a splint like this, but you can do things simpler. You can put a sandbag under the person's hand so that when the fingers sit on the hand, the fingers droop over the edge, and that will maintain a certain amount of the arch. I've seen diagrams of people who took half a coconut and put that under the hand, and again, half a coconut shell, and again, it preserves the arches of the hand. To preserve the web space, you'd have to put something between the thumb and the hand, whether it be cloth, whether it be it could be a roll of cloth, something like that, to preserve the arches of the hand. So that's pretty much in the hand. For the elbows and the knees, if possible, you want to have them in extension. If a person has their knees in flexion while they're sitting during spinal cord injury during the acute phase and developing fracture, even if they get movement back in their legs, they're not going to be able to walk because their knees are bent. So you want to have the arms and the elbows, knees and the elbows in extension when they're resting in bed. And then also important for future walking or for positioning is having the feet preventing a tiptoe contracture. And this picture in the middle is of having a cushion put at the end of the bed so that the person's feet ankles stay flexed. You'll also notice there's some towels under the ankles, under the calves that keep the heels from touching the bed that could cause a bed sore. Or this is a special kind of boot that you can buy on the internet or at a supply store that would keep the foot in a good position and avoid this tiptoe contracture. So now we've prevented the person from developing fractures. What else do we do? Once we enter the rehab phase, then we start strengthening. In the last session, the instructor talked about gravity eliminated, gravity resisted, assistive, and passive range of motion. And as OTs, we would be doing all these different types depending on the individual strength. You've assessed the strengths in their elbow flexors and elbow extensors. You've decided they have gravity eliminated strengths, so therefore you work with them on a gravity eliminated position. Or you decided they have enough strength for gravity resisted with a weight, so therefore you would work with them in pushing a weight up in the air with a weight on it, because that's a level of strength they have. We also can, gravity eliminated, one thing you can do is you can put the arms on a table, and that allows the person to do some elbow flexion and extension, even though they only have gravity eliminated strength. But there are some devices that allow the person to be more functional. You can find a device that goes over the back of the wheelchair and has a structure above the wheelchair and then springs coming down and then loops, and the person puts their arm to the loop, and that allows them to horizontally abduct and adduct their shoulders, swing their arms back and forth, even though they don't have the strength to hold their arms up. And with that device, some people, for instance, can learn to feed themselves. They can learn to reach out to the side, pick up some food, bring it back to their mouth, with their arm being held by this sling. But I also worked with a patient who had the same situation and didn't have the money to buy this device. So we attached a piece of rope to a rafter in the ceiling. We attached that to a pole, and at each end of the pole we put a small a loop to support the wrist and the forearm, and that allowed him to do things with his arms that he wouldn't be allowed to without the device. One thing to be careful of is over-strengthening a muscle. For instance, if the person doesn't have elbow extension, but they have elbow flexion, you do want to be careful of really working too hard on this elbow flexion because you can cause a contracture. The person may keep their arm in elbow in extension in flexion all the time. And you also want to be careful about too much exercises that can cause pain. One thing to remember is that the legs are made for the constant work of walking. The arms are not made for it, for the constant work of pushing a wheelchair. And it is possible for a person to develop really bad arthritis, which makes it difficult to transfer, makes it difficult to move their wheelchair, makes it difficult to do anything with their arms. So be careful with those exercises. Take it easy if the person's developing pain. And of course, as OTs, we want to use purposeful activity rather than having a person reach in the air with a weight, have them play a game whereby they have to reach in the air to grasp an item. If you're working on gravity eliminated, rather than have them reach back and forth just on a board, have them pick up something, pick up a piece of silverware from the middle of the board and put it down on the right side. Or a sport, anything that we can do to strengthen rather than pure exercise. Okay, we do some stretching because if a person has a contracture, if they have an elbow contracture in extension and they can't reach their mouth, that's going to really limit what they can do. So we do some stretching as OTs. One thing to do is make sure that it's a muscle contracture and not a bony block. A muscle contracture results when a muscle gets shorter. So for instance, if the elbow extenders get shorter, the person has trouble flexing their elbow. Sometimes though, there will be a bony growth that blocks two pieces of bone together as the person bends their elbow. The way to tell whether it's a muscle contracture or a bony block is to move in the direction of the contracture. If it gradually gets harder, then it's likely to be a muscle contracture. If it all of a sudden stops, then it's more likely to be a bony block. Stretching won't work there. The person, if they would have to have some sort of surgery or some sort of medical intervention. You do need to be careful because, as I'm sure all of you know, bone growth is spurred by movement. Bone growth in the legs is spurred by weight bearing in the legs. Calcium is deposited on the bones based on this. So that if a person is not using their legs for weight bearing or not using their arms very much, the bones get weak. They lose calcium. So when you're doing stretching, you have to be careful because you can easily break the bones. So you do have to make sure that you support the joint. If you're working with an elbow joint, you have one hand just above the elbow, holding it tight, and the other hand just below the elbow, trying to straighten out or bend. By doing this, if you hold the wrist and the elbow, then you're putting a lot of stress on the bones, the ulna and the radius. If you hold close to the elbow, you're putting less stress, you have less possibility of breaking something. And then a prolonged stretch is better than a pumping action. And then finally, if a person has active wrist extension but no finger grasp, the one thing you should not do is you should not stretch the fingers in extension while the wrist is extended. We'll talk about it later, but there's something called a tenoresis grasp, where the person needs to be able to flex their fingers as they extend their wrist. So the thing to avoid doing is having them lean on a mat with their fingers straight. If they're sitting on the mat, they should be leaning, they should be pushing down the mat with their fingers bent. As OTs, of course, we improve manual dexterity. We talked about this tenodesis grasp. It's the fact that, and any of you can try it, if you extend your wrist back, the fingers naturally flex. So even somebody who does not have active finger flexion can pick up an item by extending their wrist and then grasping the item either between the thumb and the forefinger or between the fingers and the palm. So we train people to use this tenodesis grasp. We often work with a lateral pinch because the thumb, it's easier to maintain the thumb in a position to push against the side of the finger rather than against the fingertip. And whenever possible, we try and make it a purposeful activity. A lot of OT clinics have pegboards. A lot of OTs use pegboards. Some patients like pegboards, I'll be honest. Some patients feel, but the problem with a pegboard is it's just an exercise. If you can make it into a game, if you can have the person play a game of checkers or a game of chess or some other game with the pegboard, if you have them do a work task, if they're an electrician, they need to be able to pick up small items. If you can have them do a household care task, such as sorting silverware, doing a craft activity, anything like this to improve manual dexterity is better than a non-purposeful activity as a pegboard. And again, if you are using a pegboard, you can make it a bit purposeful by having them make a pattern with colored pegs, by having them copy a pattern with colored pegs. That's involving something other than just the rote activity of picking up and putting down pegs. And then back to tenodesis, we can make a kind of a splint. This one on the right side, it's called a rancho-flexor hinge splint. And this, as the person actively extends their wrist, it pulls the fingers in. But the one on the left-hand side is one that was fabricated out of orthoplast, and it simply has a string between the piece of orthoplast around the cuff, plastic around the cuff and the fingers, so that as the wrist is extended, the fingers are pulled in. So all these devices can help somebody with tenodesis grasp to pick up items. And then finally, from the point of psychological support, this is really important for OTs. A person who's had a spinal cord injury is going through a loss. It's almost like a death. It's a death of who they were before. Before they could be active, they could run, they could do things. Now they're sitting in a wheelchair. The OT needs to understand that, and they need to help the person move through the stages of grief and come to accept their situation. They need to teach them to get pleasure from activities. They need to teach the family what the patient is going through. And therapeutic self is very important, being open, being empathetic, being understanding. So that's the presentation, but after our last session, Calvin from Guyana did express information for a little bit more information on cancer, because he said he had some patients by cancer. So we'll spend a few minutes on that, and then we'll open up for questions. So spinal cord injury can result from cancer in the spinal cord itself, but more often it's, for instance, the kidneys or the lungs may develop a tumor, and that tumor, by growing, will put pressure on the spinal cord. And that can cause the same symptoms you can get from a spinal cord that's injured. And all of these are different things that might result from symptoms that you might see if a person has a spinal cord injury affected by cancer. Pain at the site of the tumor, back pain, lack of sensation, loss of bladder and bowel function, difficulty walking, back pain, lack of sensation in arms and legs, muscle weakness. Again, all these things that we see in somebody with traumatic spinal cord injury, but caused by cancer rather than a trauma. How is it different? That's the question Calvin wanted to know. How is treating a person with cancer in their spinal cord different? One thing is that if you've had a traumatic spinal cord injury, it happens fast. Wham! You're hit by a car, you fall off something, and all of a sudden your spinal cord is injured, and you have a situation where you can't move your legs, you can't move your arms, you can't grasp things. It happens suddenly. And what we as OTs do is we say, okay, you're starting here. Let's gradually build you up. Let's gradually get you stronger, more mobile, more ability to manipulate things. A person with cancer, the symptoms will appear slowly and they'll gradually get worse. In many ways, that's more difficult because if you're suddenly encountered a situation of injury, you know you're improving. Whereas if you don't know, okay, is it going to get better? Is it going to get worse? It's more difficult to accept psychologically. The one thing about cancer is if the growth is stopped or if pressure on this from another tumor is reduced, there can be an increase in function. So that part is hopeful, but often just the name cancer will make it much more depressing and mentally challenging situation. So what we do as treatment will depend on how the person is doing on a particular day. We have to be constantly reassessing. If today the patient's tumor is pushing more on the spinal cord, they may be getting weaker, and then we have to focus on using adaptive equipment to maintain function. If they're improving, if the tumor is getting smaller and they're getting stronger, then we can do things that strengthen and increase endurance. Finally, we need to remember that in the process of addressing the cancer through radiation or chemotherapy, these can affect the nerves. These can damage the nerves. So having chemotherapy may result in decreased hand strength, decreased ability to manipulate things. It can also result in edema. As OTs, we can use contrast baths to reduce the edema, but you need to check with the doctor first. And then this is a sort of a review of what we also already said, that the person with cancer may be in greater danger of depression. It's a scary diagnosis, especially if their condition is deteriorating. Their future may be bleak. So we need to, again, using therapy to use of self, providing pleasurable activities that allow the person to do things they enjoy, but adapted to their level of function. The other thing, two things to mention is that pain is more common in spinal cord injury than from other causes. There's not so much pain. Spasticity can cause pain, but other than that, the spinal cord injury doesn't cause pain as such, whereas it often does with cancer. But other than that, the basic treatment modalities are the same as with other types of spinal cord injury. There. During the first half of this, we talked a lot. I gave you a lot of time to answer questions. Towards the end, I was worried about finishing on time, so I didn't give much time. So I hope if you have questions, if you have situations you want to bring up where you worked with somebody, now's the time to do it. While I take a deep breath.
Yep, just remember to unmute yourself before you ask a question so we can all hear it.
And also to remind you that my email address was listed on the one of the slides in this PowerPoint. So you can always contact me later on with a question or to share an experience.
So we have a question in the chat box. It says, my concern is on patients that are on postural reduction and poor compliance with positioning. Any help on this?
What do you mean by postural reduction?
I'm not sure.
I'm going to learn today.
Yeah, I'm sorry. This is from someone from Nigeria.
Okay. I'd be very happy to look into it in the future. If we don't have enough time today, the person from Nigeria can contact me directly.
He said, patient being managed conservatively.
Okay, so this would be a patient who the physicians do not want them to get up and be very active, I would assume.
And on strict supine position.
In strict supine position. And yet, I guess the assumption is the person is not observing the limitations. I guess what I would majorly do is try and find things the person can enjoy doing in the supine position. And I would talk to the patient about the reasons for the supine position. I would talk to them about the things that could happen if they don't respect the supine position. And I would talk with the family, because the family needs to know, the family needs to be supported in this. Does that address the issue? I'll be honest with you, I haven't worked with that many people who spent a long time in supine position, although I guess somebody who's had the in the acute phase of a spinal cord injury probably would.
Afiz is making a comment, but still think about the pressure relief as well, then can be done while maintaining the supine position.
Most definitely, Fiza. Yes, you need to think about how you position the patient to reduce pressure, because if they lie for a long period of time on their back and they don't have pressure relief, if they don't have either a mattress, if they don't have some way of reducing pressure from lying, they are going to develop bed sores. So definitely Afiza. Good point.
And please remember that if anyone has any more questions, you can email myself and I forward them to David if you don't have David's email. And if my email is kate.barlow@aic.edu. And last call for questions for David.
And my email is here, dtandkh@hotmail.com.
All right, well, thank you so much, David. This was great.
Good. I hope it was useful. I also, if any of you have questions based on this when you try and apply some of this information with your clients, please get in touch with me. I'm available for any sort of consultation you would like. And my email is right here.
All right, thank you so much. David, just stay on the line.
I'll do that. And while I'm here, good to be in contact with the two of you again, Afiza and Regina, and hope to discuss things or talk soon. Bye-bye.
Bye-bye. Thank you all for coming.
Bye.
Bye-bye.